Just a minute, I can't see the slides. Yeah, next slide, please. So the discussion is going to be about the adjuvant TKIs in EGFR mutant non-small cell lung cancer, then the neoadjuvant TKI in stage 3 and 2 disease, adjuvant immunotherapy in post-surgery patients who have received adjuvant chemotherapy, and of course high-risk stage 1A and port after complete resection and adjuvant chemotherapy. Next slide, please. So coming to this first study, next slide, of adjuvant gefitinib, which was a impact study where gefitinib was compared to cisplatinum and vinorelbine in stage 2-3 lung cancer. Next slide, please. So these were the outcomes that, there was no difference in the survival. And also, if you look at the subgroup analysis, only those patients who are above the age of 70 years showed some benefit, and some benefit for deletion 19, but not for the L858R mutation. Next slide. So I want to know from the panelists, so can we start with Dr. Vipul Doshi, that do you do EGFR testing in the adjuvant setting?
Yes, madam. We usually do EGFR testing in adjuvant setting, madam.
And do you consider using adjuvant TKI in those patients who are EGFR positive? Given
Yes, madam.
the results from ADORA?
Yes, madam. I would counsel for each and every patient in an adjuvant setting for osimertinib, but only few of them you would be able to take because of the cost issue.
So, suppose you had a generic, so would you actually give it to all patients with early stage resected EGFR positive lung cancer?
I actually do not prefer using generics, ma'am. If it is
no, I'm saying if it was available, that's what I said.
I would rather ask them if.
And cost is not a factor.
If it is available and the cost is not a factor, then I would rather use it in adjuvant setting. Yes, ma'am.
But all stage 1 or only those shown in the ADORA study?
Only those shown in the ADORA study. Stage 1, I am not yet sure.
Okay. Now, Dr. Kripa Bajaj, why is the ADORA study positive as far as the disease-free survival is concerned, but the Japanese study is negative? Is there a difference between the two studies?
So not only studies, I think drug efficacy is also quite different, ma'am. Osimertinib is quite efficacious. We have seen all studies, fluoride, deep fluoride, any studies in metastatic setting. And ADORA trial, there is significant difference in CNS metastasis-free survival, further recurrence-free survival. So I think it's more of efficacy of the drug, I believe, than the study design or inclusion criteria.
Yeah, so I think that is the most important thing, the drug that has been used. Do you think the use of chemotherapy allowed in the ADORA study, whereas chemotherapy wasn't allowed in the Japanese study in the experimental arm, do you think that made any difference?
So even in ADORA study, 60% received chemotherapy, 40% did not receive chemotherapy. In both arms, there is significant difference in survival is there.
Yes, so that is not the reason. So one of the important reasons is the efficacy of the drug itself, and second most important is the CNS penetration, because in the Japanese study, the CNS relapse was almost 24%, whereas in the ADORA it was just 11%. So there is a large difference. So that also is very important. Now, coming back to Dr. Vipul Doshi, that are there any concerns about the use of adjuvant TKIs in EGFR mutated non-small cell lung cancer? So, do you think there are any concerns about the adjuvant use?
I actually haven't got the concerns in the sense.
You're using the adjuvant TKI, osimertinib, You're going to give it for 3 years.
3 years, yes, ma'am.
Are there any reservations or concerns about this use of adjuvant TKI?
Not really.
What about, you don't have the overall survival data, and as you know, the Chinese study was negative. Next slide, please. If you can just show all the adjuvant studies. So if you look at this, if you look at the Chinese study, they reported no significant overall survival improvement because those on the placebo arm, when they progressed, they got the TKI, and they did just as well. So, do you have concerns? Because after all, the TKIs only delay the progression. They are not, tumoricidal. So, do you have concerns about that?
Mm, can be a possibility, but this the failed trial, the Chinese trial, were using erlotinib or geftinib, and this actually we are talking about osimertinib, which is a better TKI as compared to those.
Yeah. So, Dr. Vipul Doshi, you have to say anything here?
Can I add one thing on this
Yes.
one?
Yes.
So all the trials, like whatever the EGFR mutated beta-erlotinib and gefitinib, it hasn't shown any benefit post chemotherapy or without chemotherapy. Not much difference is that whoever received chemotherapy compared to the this thing. So whoever are not fit for chemotherapy, who are not affordable for osimertinib, I think it's a fair study, fair enough to offer gefitinib. The adjuvant Sitong trials have shown elderly patients, they tolerated well. Whoever cannot tolerate chemotherapy can tolerate TK as well. So in that set, we can offer gefitinib, but not other patients. We can offer EGFR mutated one, erlotinib or gefitinib. But osimertinib score really big in all aspects compared to these two TKs.
So, in our setting where many patients cannot afford adjuvant osimertinib, will you offer gefitinib?
So it's again unfit patient who cannot tolerate cisplatin. So then in that setting, we would like to offer gefitinib, ma'am, but not other people.
Yeah. Next slide, please. So these are all the meta-analysis. And again, in this, there was no overall survival benefit, though progression-free survival benefit was seen. Next slide. Next slide. So now we come to the next study, and that is the, I'm sorry, I'm not able to involve the surgeons and the radiologists and pulmonologists as yet, but I would be involving them later. So if you come to the Empower study, where atezolizumab was given as adjuvant therapy after completely resected stage 3 and who had received adjuvant chemo. So I would just like to ask Dr. Rajesh Mistry, how do you deal with very shortly, briefly, stage 3A lung cancer, 3A and 3B? How do you decide the resectability? Dr. Rajesh Mistry? Is he there? Or Dr. Devyani?
Yeah, hi, madam. So for 3A lung cancer, which would be single station N2, I think during the mediastinoscopy itself, we try and see whether we can get an R0 resection at the node. So only if it is single station resectable N2 disease would we think of surgery in this population. If it is multi-station N2 or if it is unresectable, that is, there's no strict say 3 centimeters, but if it's unresectable N2 or obviously N3 disease, then it goes beyond the scope of surgery into the realm of chemotherapy and radiation.
Yeah, and of course, here they had not mentioned what is the staging that they did for the mediastinum, but right. Dr. Ahuja, I'd just like to bring you in here. What are the results of mediastinal staging with, PET CT, and would you like to confirm, Dr. Devyani, with either mediastinoscopy or EBUS?
Yes, ma'am, definitely. So PET CT along with CT provides good enough sensitivity and specificity, but I think if you're going to operate the patient, then a mediastinoscopy to confirm is mandatory, is required.
Dr. Rajesh Mistry would like to say something. Are you there? Okay, so then, next slide, please. So I'd like to come back to the medical oncologist. Dr. Vipul Doshi, which patient in this study showed a significant disease-free survival benefit? Can you just tell us that?
Uh, when the PD-L1 positivity score was more than 1%, and even better, if it is more than 50%, those scored better DFS as compared to the chemotherapy alone.
Yes, but of course, it was stage 2 to 3A. I mean, in that particular thing, the 1B was not included. So I think that has to be kept in mind. And Dr. Kripa Bajaj,
Yes, ma'am.
who showed this significant disease-free survival benefit?
The all comers are like more than PD-L1 positive, both showed benefit, but the significant benefit is seen in more than 1% people and quite significant in more than 50% people, ma'am. From stage 2 to stage 3, like they were included patients were there. So all showed benefit, but significant in more than 1%.
Okay. So, would you now, do you know whether this is included now in the NCCN guidelines?
No, ma'am, we actually have to wait for the OS data, but we can offer the data is there, but it's too early to include.
Yeah, but if you look at the 2022 version, then this has been included in the adjuvant setting. So they have not yet waited for the overall survival data. Now, if you were to do the PDL1 testing, by which method would you do it according to this study? Because they did modify the testing method in between.
SP263 is the ideal, ma'am. Like I'll go by that antibody.
And do you think the safety profile is acceptable?
Yes, ma'am, it's quite acceptable. It's like any other immunotherapy profile, so it's acceptable.
Yeah, there was some increase in the liver enzymes and all, but all these toxicities we are able to deal with. I'd just like to ask Dr. Amrita Athavale, have you come across cases of, lung toxicity due to either the TKIs or the immunotherapy? Have they come to you, or your medical oncologists have taken your help in this regard? Dr. Amrita Athavale, is she there? Okay, so then now would you consider PDL1 testing in stage 1B here?
No, ma'am, 1B not it. So from stage 2 is the inclusion, so from there only I'll start, not 1B.
Yes. So in the conclusions, it was clearly stated it was PDL1 positive stage 2 and stage 3 that benefited. Next slide, please. So this is what, and it was shown by the previous speaker. So I won't dwell much on this, just to show that all patients benefited in the subgroups which are PDL1 positive. Next slide. Now stage 1 and adjuvant therapy. Next slide. So what criteria do you use to offer adjuvant therapy in stage 1? So can you tell me, Dr. Kripa Bajaj?
More than 4 centimeter I'll definitely include, ma'am. And LVS is a very soft indication for us. But more than 4 centimeters, definitely yes.
And what about lymphovascular emboli?
Yeah, ma'am. LV is a soft indication. There is a controversy there around it. Yeah. But more than 4 centimeters strongly yes. LVSI, it depends on institution to institution. I would like to add only if it is more than 4 centimeters. LVS really soft indication.
And Dr. Vipul Doshi?
Yeah, I agree with Dr. Kripa said. If it's more than 4 centimeters, then I'll definitely push for it.
Yeah.
LVSI is a soft indicator.
Yeah, next slide. So this was the study shown by Dr. Uma, and EGFR status seemed to influence the outcome of chemotherapy. Would you accept this data and use EGFR to decide on chemotherapy? Dr. Vipul Doshi?
Actually, this is a retrospective data,
right.
And I would wait for more data to
decide
on EGFR positive or negative to choose the chemotherapy. I would rather use age-old, like more than 4 centimeters and other risk factors to decide on it.
Yeah. Next slide. So these are the NCCN guidelines, and as you can see that both osimertinib as well as atezolizumab has made its way here. into the adjuvant setting. Now, I would like to ask Dr. Vipul Doshi. You have the 816, which checkmate 816, where nivolumab with chemotherapy has shown good results in the neoadjuvant therapy. So, if you were to use that in future, whenever you had the, it was included in the guidelines, then definitely you would have problems in using it in the adjuvant setting, right? Dr. Vipul Doshi?
I'm not able to comment on that. Maybe Kripa can take it.
Okay. Next slide, please. So now coming to, we can slip this slide because, yeah. So this was the fourth study, and this is regarding stage 3A and 2 adenocarcinoma. I want to know, have you used TKIs as the EGFR? Have you used TKIs in the neoadjuvant setting? Dr. Kripa Bajaj?
Oh, I never tried TKS in neoadjuvant setting. I have never tried it.
Yeah. So I think for shortage of time, because the last study is very important. Can you go to the next slide? So this was the emerging study again from the Chinese. It was a phase 2, and of course it did not reach the level of significance in overall survival, though they had shown an improvement in the progression-free survival, which was submitted 2 years back at the ESMO 2019. And the reason they gave was whatever the post-hoc analysis, subsequent treatments did very well. So I think you're right. I don't want to dwell on this study because it's still in the experimental phase, the use of neoadjuvant TKIs. Next slide. Now, coming to the most important, one of the most important is the use of radiotherapy in those patients who are resected stage 2, stage 3A and 2 positive. Now, Dr. Devyani, you have resected the patient and you have given, the medical oncologist has given chemotherapy. So, would you be referring any patients for radiotherapy?
Thank you, ma'am. So, as per the latest data from the LUNGAT and the POTSI, even in our institution, we have stopped giving adjuvant radiation for patients with persistent N2 post chemotherapy. But having said that, I think it was very well illustrated in the last talk that probably there is still a subset of individuals who might benefit from adjuvant RT. So I would definitely check with the operating surgeon whether they were very comfortable with the R0 resection status that they achieved at the lymph nodes. And if there is any doubt regarding the R0 resection at the lymph nodes, then I think post-op radiation would still at least deserve a referral.
So how do you want the pathologist to report on the nodal stations? Like, are the stations important or the number of lymph nodes dissected are important? What is important?
I think both are important, but the stations would be predominantly important because as we know, single station versus multi-station N2 changes the prognosis quite dramatically. And also, if we look at the study now that even the POTSI, that more number of positive lymph nodes again becomes one of those subsets which are veering towards benefit with post-op radiation. So I think they would need to report both.
Yeah. So Dr. Rajesh Mistry there. Am I running out of time?
4 minutes left, ma'am.
Yeah. So Dr. Rajesh Mistry, are you there? Is Dr. Rajesh Mistry there? Okay. So, Dr. Devyani, what sort of mediastinal nodal dissection do you do, and when sending the specimen to the pathologist, because you said the stations are important. So, what are the things to be looked at when you send the specimen?
Right. So generally, we start with a mediastinoscopy, especially if there is any chance that this patient is going to be a stage 3A. And during a video mediastinoscopy, we address both the right and the left paratracheal nodes at level 2 and 4, as well as the subcarinal lymph nodes. and we send them in separate packets for frozen section analysis. If any one of them comes positive, we prefer to give neoadjuvant chemotherapy to these patients. Now, if we operate a patient post
Neoadjuvant or
neoadjuvant
adjuvant?
chemotherapy,
Yeah.
we go ahead with a systematic mediastinal lymph node dissection. So, whether it is a left sided lung dissection or a right sided, the stations that we do clear are the upper and lower paratracheal, that's 2 and 4. Station 7, that is the subcarinal lymph node station. The station 8 along the paraesophageal and the inferior pulmonary ligament nodes. Left sided resections, we also clear the prevascular and the AP window nodes. And all these nodes are sent separately in separate packets for histological examination.
Well, we don't have a radiotherapist in the panel. So we're missing a radiotherapist. Would you want the radiotherapist to give radiation if?
Madam, Tiranjan
Yeah.
will be there. He can take the question if you want.
Who, doctor?
Dr. Basu is there? Tiranjan Basu?
Is he there?
He's
Because he is not mentioned in the panel.
he's not in the panel, but we just thought
Yeah.
we can
Then
co-opt.
can I have his opinion on this? That if there are 6 to 8, there is some emerging data about the benefit of radiation if there were more than 6 to 8 nodes positive. Dr. Chiranjan?
Srinanjan.
Yeah, Nilanjan. Sorry. Yeah.
Uh, yeah, if more than heavy nodal burden, yeah, there are some data like you rightly said. Even the one I presented in that also the same group from Beijing have done one analysis on number of node positivity, number of node dissected, number of positive to the number of node dissected. So more the nodal yield, yes, there are sub cohort where it has a local recurrence free survival benefit with port.
Yeah. So what about extranodal extension? Is that a criteria?
Not really for radiation in lung like other
Okay.
sites.
Okay. No, just to make it clear, where you would consider, given the negative results from all these studies. Next slide. Yeah. So now the thing that was brought out was, if you look at all the 3 studies, one of the main deficiencies were it is a very long period of accrual when many things have changed in the radiotherapy field as well as the systemic therapy. And if you look at it as it was shown in the presentation, that the local recurrence free survival was significantly improved, and the deficiency was actually because of the distant metastases which could not be reduced by giving the local therapies. But now with the improved systemic therapies, so again coming back to the radiotherapist, do you think that this should be revisited
From
because of its effect on local recurrence?
so traditionally, ma'am, the role of radiation is always to prevent local recurrence. Of course, the more the local recurrence can be reduced, it definitely translate into OS benefit. So it should be revisited. Yeah, I would definitely say as radiation oncologist.
Yeah,
it should be
because now
revisited.
you have, the therapies, systemic therapies used during those studies, it ended in 2017. So you didn't have, osimertinib and drugs like that. So, now you have much better systemic therapies. So I think, so is there any trial in the offing now to relook at this?
When I checked about the post of adjuvant RT data, there are a couple of about 10-15 trials going on across the globe on these molecular classification and adding whatever may be EGFR TKIs with also after the completion of adjuvant chemo and with port. So all will take at least 3 to 4 years to complete, and then we'll have some data.
And in case you do give port, then in some select patients, what's the dose and uh, what are the toxicity concerns?
With IMRT, even the IMRT 3DCRT combined port C, that is the only randomized data published, has has actually none of grade 3 toxicity. Even the grade 2 is less. So the grade 1, which is like mild cough maybe from pneumonitis aspect and mild to moderate dysphagia with grade 2 esophagitis, would be around 15% or so, even less than that. And if it is sole IMRT, then it will be further reduced, I presume or believe.
and the dose should not be more than 54, because people have tried dose escalation in port and which has detrimental outcome. So the dose should be between, it will be 50 gray equivalent. People do it 1.8 gray, people do it 2 gray. So it will be 50 gray equivalent, and that is good enough. The important is to choose the right technique, which should be IMRT in today's time, and even with some sort of image guidance for sure, so that to reduce the normal lung volume receiving radiation, and also
Madam,
to
we are
follow standard
time.
guidelines.
Yeah, so the last question, that is for Dr. Ahuja. So, are you involved with, doing the scans for, or the treatment planning? Dr. Ahuja?
Yes, ma'am. So, we are involved with the planning and what marking of the lesions properly, so that the radiation can be well given.
Yeah. So I think I've come to the end of my panel discussion. Well, I'd again like to thank the organizers and the panelists for this panel discussion, and I hope there have been some take-home messages, especially that the use of adjuvant osimertinib has come in 1B to 3 stage. When it comes to adjuvant immune checkpoint inhibitor, atezolizumab has received the approval as adjuvant therapy for PD-L1 positive, stage 2 and stage 3. Neoadjuvant TKIs do not have a role at the moment, and very limited selected patients would consider port, but otherwise it has shown no survival benefit. Thank you.